Hello friends. Welcome to Scrub Life Nursing Tutorials. In this video, we are going to learn about pneumothorax, its type, causes, clinical features, diagnostic tests used to rule out this, and its medical and nursing management. So without delay, let's dive into it. In pneumothorax, positive pressure, atmospheric air, accumulates in the pleural space, which leads to increased intrathoracic pressure and reduced vital capacity. Normally, pleural space have negative pressure, which helps the lungs during inhalation to inflate easily and prevent the lungs from collapsing. But in pneumothorax, this loss of negative intrapleural pressure leads to lung collapse, resulting in respiratory distress. Now move to the types of pneumothorax. First is the spontaneous pneumothorax, which happens due to rupture of pulmonary bleb, which are the small air-containing spaces deep within the lungs. Next is open pneumothorax, which happens due to opening in the chest wall, resulting in entry of positive atmospheric air pressure in the pleural space. It is caused by penetrating chest injuries or surgical procedures. Next is tension pneumothorax. It's a medical emergency, because the pressure keeps on building with each breath, in the pleural space, but cannot escape. It happens due to blunt chest trauma or mechanical ventilation with PEEP. Next we'll discuss about the causes of pneumothorax. First is spontaneous pneumothorax. It is primarily caused due to rupture of pulmonary bleb, and secondarily due to underlying lung diseases, that weakens the alveoli. Open pneumothorax is caused by penetrating chest injuries like gunshot, stabbed with knife etc. or surgical procedure like thoracotomy, central line insertion, lung biopsy, chest tube removal etc. Tension pneumothorax is caused by blunt chest trauma or mechanical ventilation with PEEP, CPR, or barotrauma. Let's move to the clinical features of pneumothorax. It includes sudden unilateral pleuritic chest pain with dyspnea, which is difficult breathing, that increases with exertion. Next, decreased or absent breath sound on affected side. Next, decreased chest expansion unilaterally, that's affected side. Next, tachycardia, which is increased heart rate, tachypnea, which is abnormally rapid breathing, hypotension, which is low blood pressure. Next, subcutaneous emphysema. It happens when air gets trapped under skin. It is evidenced by crepitus or crackling sound on palpation around chest or neck. Next is hyperresonance, which is louder drum-like sound on percussion, cyanosis, which is the bluish discoloration of skin and mucous membrane due to lack of oxygen in blood. Next, sucking sound with open chest wound, and tracheal deviation towards unaffected side in tension pneumothorax. Next we will discuss about the diagnostic tests used to rule out pneumothorax. This includes chest X-ray. It is the first line and most commonly used. It shows a visible visceral pleural line with absence of lung marking beyond it. Next is CT scan. It shows most accurate findings. ABG shows hypercapnia, increased PCO2, and hypoxemia, decreased PO2 level. Now we will discuss about the medical management. For small pneumothorax, especially spontaneous, monitor the patient closely. Provide supplemental oxygen, and repeat X-ray every 6 to 12 hours. It usually resolves its own in few days. For moderate pneumothorax, needle aspiration is done with a 14 to 16 gauge needle, inserted in second intercostal space at mid-clavicular line. Air is aspirated until resistance is felt or the patient improves. X-ray is repeated to confirm lung expansion. For tension pneumothorax, which is a medical emergency, if suspected, do not wait for X-ray. Immediate needle decompression is done. For large, persistent or secondary pneumothorax, chest tube drainage system is inserted with 28 to 32 French tube, at fifth intercostal space, mid-axillary line. Now we'll discuss about the nursing management of patient with pneumothorax. It includes monitor breath sound on both sides and rise and fall of the chest. Assess vital sign especially respiratory rate, blood pressure, heart rate, and SpO2. Provide high Fowler's position and O2 as prescribed. Apply non-porous dressing over open chest wound. Observe for sign of worsening like increased dyspnea, chest pain, subcutaneous emphysema and decreased breath sound etc. In patient with chest tube drainage system, make sure it's working properly. It may have intermittent bubbling. Excessive or continuous bubbling indicate leak in the system, and no movement in the system indicate kinked tube or the re-expansion of the lungs. Assess drainage amount and color. If chest tube dislodged accidentally, immediately apply sterile occlusive dressing over site and notify doctor. Verify reduction or absence of chest pain and dyspnea. Alright guys, that's all for today. If you found this useful, don't forget to like the video and subscribe Scrub Life for more tutorial.